Hi, my name is Dr. Renee Hilton. I'm going to be presenting today on bariatric surgical emergencies in the pregnant patient. I want to thank SAGES as well as Dr. Ann Rogers for inviting me to speak here today. I have nothing to disclose. Objectives for today are to identify the most common surgical emergencies in pregnancy after bariatric surgery and describe the workup of these bariatric emergencies so that we can identify and promptly treat them. I want to specifically focus on intervening on internal hernias after gastric bypass. For this, I have a case presentation with video. Pregnancy and bariatric surgery. In the US, 80% of bariatric surgery patients are female, with 50% of these being of reproductive age. With ACOG now recognizing bariatric surgery as a promising pre-pregnancy obesity treatment, it's very possible that you'll encounter not only a post-op bariatric surgery patient, but also one who is either pregnant or desires to become pregnant in the future. The most common operations that we see today in bariatric surgery are the band, sleeve, and bypass. While the band is more of a historical operation for most of us, we still do see a lot of patients who have the band in place. The two pieces of literature to the right were great resources when preparing this talk, and also when I've had patients in the past who were pregnant after bariatric surgery. I recommend them as a resource. So we're going to talk about the adjustable gastric band first. What you see on the imaging here is a band in appropriate position, the plain film in the middle confirming that. So complications after the band, again, you're more likely to see a late complication in all of these cases than early, simply because these patients are now pregnant. In the late complications for bands in pregnancy, the most common thing that you'll see is band slippage. I'm going to go through the management for that. But also you could possibly see an erosion or a perforation. In a patient who's stable, the first step with the band is going to be deflation. So you can insert a needle into the port to withdraw the fluid. For most band patients that are in fact just slipped, this will resolve their symptoms. If the patient remains having symptoms, MRI would be the imaging modality of first choice. Sleeve gastrectomy is the most common procedure being performed today on reproductive age females. This is a normal sleeve. For complications after sleeve gastrectomy, again, the most common thing that we see is dehydration. However, in the late patients, if you have a pregnant patient with a complication, the most likely thing that you would see is a small bowel obstruction, which can be managed the same as it would for any normal anatomy patient in pregnancy. Again, most of the focus today will be on the gastric bypass. So complications after a gastric bypass, again, are mostly going to be late complications when seen in pregnancy. Small bowel obstruction and internal hernia are going to make up close to 10% of these altogether. Certainly is possible to see marginal ulceration or perforation, particularly in high-risk patients such as smokers or NSAID abusers. So we'll go through the workup and treatment specifically for small bowel obstruction for the scope of today's talk. So internal hernia, how do they present? They can present in a lot of different ways. Clinical suspicion in any patient who presents with the following signs and symptoms after a bypass is needed: epigastric or general abdominal pain, nausea, sometimes without vomiting, elevated LFTs, or imaging that would suggest a distended gastric remnant on CT scan, or mesenteric swirl. Internal hernia can occur at one of two places in an antigastric bypass. First of which is at Peterson's hernia. That's between the mesentery of the transverse colon and the roux limb. Could also occur at the mesenteric defect, which is closed when you do your jejunal anastomosis. In a patient who has a retrocolic roux limb, you can also see an internal hernia at the site where you open the mesentery. On CT scan, as shown here, two things that are kind of pathognomonic of internal hernia. The image on the left is showing a mesenteric swirl. And the image on the right shows bowel dilation, also shows some dilation of the remnant. So both of these things should really prompt you to intervene urgently on these patients. So how do you manage an internal hernia in pregnancy? In a patient with an acute abdomen, imaging is not necessary. If your clinical suspicion is high, the patient is unstable and has acute abdomen, proceed to the OR. In unclear cases or in cases where the patient is stable and you have time for imaging, MRI is the first line choice in a pregnant patient. If MRI is not available, you can use a CT of the abdomen to confirm the diagnosis. For the surgical approach, this is largely going to depend on two things: both surgeon comfort as well as how far along in pregnancy is the patient. Are you comfortable doing laparoscopy, or are you going to be more comfortable doing this case open? Whichever you can do safely and get the patient to the OR expeditiously is the one I would recommend. SAGES has great guidelines for performing laparoscopic procedures on pregnant females. And I would recommend using those for a resource as far as selection of location of entry, pressure, etc. I would also recommend consulting an OBGYN prior to going to the operating room in the event of fetal distress and the need for an urgent C-section. So our case presentation for today is the 38-year-old female who presented to me after a sleeve in Mexico was complicated by not only a leak, but later a stricture. I converted her to a Roux-en-Y gastric bypass. She did very well. 2 years after Roux-en-Y, she underwent IVF and was successful in getting pregnant. Her pregnancy, though, was complicated by severe nausea and vomiting and hyperemesis gravidum. So what would you do? It's a pretty complex patient. We arranged for both follow-up with a high-risk OBGYN through our MFM group, as well as in our bariatric clinic, where we could focus on labs, nutrition, and make sure that she was staying on track. So it was a multidisciplinary approach with a lot of communication and education both ways throughout her pregnancy. So we did have to scan her once during pregnancy. The rest of the times we were able to just assess her clinically. This is a CT scan that was done after she came in with acute abdominal pain in the setting of nausea, vomiting. She had a healthy intrauterine fetal pregnancy at this time and no internal hernia. Our goal working closely with her OB/GYN was to avoid scanning her frequently in pregnancy. If the MRI was not available, we knew that we could do 1 to 2 scans safely based off radiology recommendations and OB/GYN recommendations. And this was, in fact, the only scan she got while pregnant. This is the same patient, but a different day. This was in the immediate postpartum period. It was less than 2 weeks out from a normal vaginal delivery. And you can see here on this CT scan, she does, in fact, have an internal hernia. So immediately after these images, we went to the OR for a laparoscopic repair. You can see here, we started at the gastric pouch and we're going to run the Roux-en distally. And pretty quickly, we encounter the site of this mesenteric defect and large internal hernia. We initially tried to reduce, you can see the JJ there. We tried to reduce the intestines by pulling it through. We were getting some resistance, so I just changed my tactic a little bit, and we were able to push the remaining bowel through the defect. Once we were able to do that, you're going to see us close this defect with a suture. This can be done several different ways, but my preferred technique is to use a purse string suture, just continuously sewing and then bringing that together. 1 stitch was all that this needed. Once we had repaired the defect, we assess it here, and then we reran the entire Roux limb to the JJ. We ran the BP limb, and then ultimately also the common channel. I think this is an important technical aspect of these cases. If you already have the patient there, check all of your limbs, check everything and make sure you're missing nothing. You can see there the appendix and cecum, knowing that we reached the end. So in conclusion, the obesity epidemic continues unabated and bariatric surgery remains the most effective treatment. All surgeons can expect to encounter a bariatric surgery patient, and with 80% of the patients being female, pregnant female is certainly possible. These are acute complications, must be diagnosed, treated expeditiously to achieve optimal outcomes. Thank you.